Excellent. This meeting is being recorded because it is a public meeting, and it will be posted on our committee's webpage shortly after we conclude. And for everybody's reference, today's agenda can be found under the first tab in our materials. And Dr. Judy Zerzenthal, our committee chair, will now call the meeting to order. Over to you, Judy.
Excellent. Thank you. Welcome, everyone. It's 2:03, and I call the June 28th meeting of the Advisory Committee on Primary Care to order. Thank you all for joining us today. As you can see on the screen, it's our agenda for the day. So we'll start with roll call after this, then we'll vote to approve the meeting summary for the May committee meeting. At 2:10, we will have our public comment. After that, Shane and Amy, on behalf of the Center for Evidence-Based Policy, will lead us all in a discussion to identify data collection barriers and propose potential solutions. After that, I will finalize, there's a couple of codes that I said we'd come back to that we need to review, and then I'll talk about next steps for that. And then finally, Amy and Shane will provide an overview of preparation for the July meeting by reviewing a framework for policy recommendations. So some of what we talked about in the last meeting will come through to here. And as always, I encourage committee members to ask questions and provide feedback that will help our discussion. And thanks for all your time and effort today. So let's get started with roll call. I will call on members by the first name in the order listed on the agenda, which is alphabetical order by last name. So might be a little tricky, but when I call on you, please unmute your microphone. You can come on camera if you like to wave at us and let us know that you're here, and then please mute your microphone again. So Crystal. Okay, I think she's not.
I'm here.
Oh, you are. Oh, perfect.
You're just getting us set up. Thank you.
Oh, excellent. Just in time. Sharon Brown. Tony. Michelle.
Hi there. Nice to see everyone.
Thanks, Michelle. Nancy.
Here.
Thanks. Tracy. I just saw David.
Hello.
Hello. DC.
DC let me know he was not going to be able to attend, so he is not here today.
Okay, great. The other Sharon.
I'm here.
Excellent. Hello, good afternoon. Greg. Chandra. Meg. Cheryl. Lon.
Hello, I'm here.
Hello, great to see you. Kevin. Eileen. Katina.
I'm here.
Hello. Oh, somewhere nice too. Some leaves and sunshine. Mandy.
I'm here.
Hello. Jonathan.
I'm here.
Thanks for joining. Sarah. Linda. Sean. Stacy.
Hi, everyone. I'm here.
Oh, hey. Hello, Stacy. Ginny. And Maddie.
I am here. Good afternoon.
Perfect. Jean Marie, do we have quorum?
I am not sure. I wasn't keeping a close tab. We might be a little shy today, so that's Serena, can you let us know how many folks you counted? Possible.
Yes, hold on one second.
Yep,
We
thanks.
can look
We'll-
at that.
We'll keep
I'll,
track of it. Yeah.
okay, that sounds great. And I'll turn it back over to Jean Marie, who will go over the minutes.
Yes, thanks, Judy. If you all could join me in turning to the meeting summary and the materials. And the recording of the last meeting was posted on our webpage. Is there any discussion of the meeting summary or proposed changes? I will say that I think someone caught notation of a member absent who was not actually absent. So if you notice anything like that, please do let us know and we'll fix it.
Yes, I'm listed as both present and absent.
Okay, well, you can't have both. So yeah, I will get that fixed. Thanks, Jonathan.
I was present, but really a delight to be Schrodinger's cat for even just a moment.
Yes, you're quite talented.
Yes. Any other notes from folks on the meeting summary?
I just noticed Sharon Eloranta is in the same position. She was both present and absent.
Oh my, there I am.
Yes, and I think you were there, if I recall correctly.
Yes.
Okay. So Jonathan, Sharon, and Cheryl, because Cheryl was the one who let me know. I think she was on the next page if we advance to that. Oh, maybe not. Nope, it was Greg. Anyway, any other notes or comments? Okay, with no discussion, I will say all in favor, say aye.
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 Excellent. Any opposed? Okey-doke. With the slight updates, I will have that approved by consensus. And next, we're going to turn to public comment. And I will let Dr. Zerzenthal lead us through that.
Okie doke, thanks. So now is the time for public comment. When you're called upon, please state your name and affiliation, if any, before you talk. And just raise your hand once. There's a raise your hand function. And you're also welcome to provide comments in writing via email at any time. This is a reminder that this is the time for public comments. Any questions and answer sessions during the committee, during the meeting times are for committee members only. And let's see, do we have anyone that wants to say anything?
No, there weren't any who had signed up in writing that I saw, so.
And we are exactly at 2:10, so it should be the time.
Yes.
And taking a view of the people, it doesn't look like there's anyone. Yes.
Not seeing anyone either.
Yep. There are 4 attendees that are public, but yes, I think that is fine. So let's move on to the next section then. I'm going to turn it over. I don't know who's talking first, Amy or Shane, but let's start a discussion of primary care data collection barriers and solutions.
And I think we're also going to turn the control over to Shane and Amy as well.
Yeah, thanks very much, and thanks for the intro. It's good to see you all again. We are continuing down the path of figuring out how to measure and then pay and support primary care, and we're going to be focused really on measurement for the first part. Just as a reminder, as I foolishly try to multitask to share my screen and talk here. But in the last meeting, we had 2 experts, one that was working at the national level and one at the state level. And I think one of the key takeaways is that this stuff is actually pretty complex. So here, give me 1 second here because I truly cannot multitask. All right, there we go. And can you see the presenter mode or the not look right? Okay,
regular great. Doing it.
All right, perfect. Thanks very much. Also, there's a lot of devil in the details, so it's complex and a lot to work through. So what we thought we would do today is to identify some of those gaps and challenges for primary care expenditure data collection that have been found in prior efforts or that were flagged in the presentations that we heard in the last meeting. We also want to spend just a little bit of time level setting, talking about what the status quo abilities for the state to collect and calculate expenditure totals are, so that you can kind of understand, like, despite what you may have heard in presentations or some of the other lessons learned that we're trying to learn from other states, where you're at and what that means for some of the gaps that you still have and that you might want to recommend policies to address. So we'll talk about that. After we get through talking about data collection and policies there, well, we do have one single individual outstanding code for the primary care definition that was brought up via email in between meetings that we want to bring to your attention and give you the opportunity to vote on to either include or exclude. And then lastly, and I think we'll have plenty of time, honestly, we do want to start to tee up what we'll be tackling in the upcoming meetings. So there's really two parts to that. In the future, we're going to be looking at some of the data analysis based off of the primary care definition using kind of a sample data set, and then also getting back to the hard work of fleshing out some of the policies to support primary care. So remember that 4-quadrant framework that included things like direct investment, workforce, and all of that. We have an initial list of ideas for exploration, but we do need to go down a few levels of granularity and also make sure that we have the right set of policies to move back up to the board as recommendations from this group. So we'll tee up that discussion after we've completed our other goals for today. So back to the data component, we are focused on this middle ground, which is really around the data collection. So report on barriers to access and use of primary care data and how to overcome them. Reporting the annual progress needed for primary care expenditures to reach the 12% and tracking accountability for annual primary care expenditure targets. And then just to ground the conversation, this is language from the bill text that drives all of this work. So to the extent possible, the report has to include annual primary care expenditures for the most recent year for which data is available by insurance carrier, by market, or payer, both in total and as a percentage of total healthcare expenditure. So nothing groundbreaking there. I think that's pretty aligned with what you would basically expect. But also we'd want to break down the expenditures by relevant characteristics, such as whether expenditures were for physical or behavioral health, by type of provider, and by payment mechanism. Hang on to that concept. That's something that we'll be tackling a bit today. And then also, if necessary, identify any barriers to the reporting requirements and propose recommendations for how to overcome them, which is also part of what we're working on today. So again, just going back to the presentations last time, I know that the second presentation in particular, it was no holds barred. This is what reality looks like when you try and do this hard work. Down to some pretty nitty-gritty detail. And I think it was fairly, probably a little bit overwhelming. And I do want to just start the conversation today, just to level set on what you have in place today and what some of the implications for your existing infrastructure are as you think about how do we meet the statutory obligations going forward. So today you actually have two primary data collection strategies or sets of infrastructure, however you want to characterize that. The first is that you do have an all-payer claims database. Some of the key characteristics that are relevant for this discussion is that the APCD includes detailed data submitted by a subset of payers to the APCD. So detailed data would mean you're looking at individual services for individual people, for individual providers, like down to the individual claim level. By subset of providers, it's just important to note that there are federal regulations that prohibit states from requiring certain payers to report to things such as APCDs. So these would be payers that are covered by what's called ERISA. So I think that's just something important to note, because that's a point of contrast when we talk about the other option that's currently utilized for calculating primary care expenditures. The next thing, or just important to notice, or to note that HCA will ultimately be calculating and reporting out these results, but HCA does have access to the APCD. Just that same, so this is just really reiterating, subset of payers does not include ERISA plans. And also importantly, thinking back to the presentations last time, it does not include non-claims based expenditures. So it's really just getting the subset of claims that are important. Your second strategy is actually the HCA aggregate data call. And this was really a process put in place to support this very effort. It's different from the APCD data collection in that it's really aggregated data submitted by all payers directly to HCA. It does include some ERISA plans data. It's a very specific circumstance, and it's reasonable to assume that it's not all ERISA plans data. Essentially, the data that's collected from these plans is the aggregate data call is asking for data from all of the major payers, and to the extent that they serve as a payer for utilization that falls under ERISA, it would be included in those aggregated totals. The implication for that is that ERISA plans and that subset of utilization isn't carved out. It's just reported as commercial data. But it's nice that you actually have a mechanism that you are capturing some of that data, because again, there are federal prohibitions on mandating data collection for data that falls under ERISA. The other thing is that that is a key distinction is that it does include the non-claims based expenditure. So plans are asked to report on non-claims based expenditure, which again, going back to the last meeting, is really a key component and a non-trivial contributor to the total expenditure. And here's kind of the silver lining about having, despite the fact that you have two different processes by which you collect data, your second one actually has a lot of flexibility, and that HCA can update the reporting specifications to meet current policy needs regularly. And specifically, I want to call out, starting with next year, what you would expect to see is the updated primary care definition, for example. So that you've been working on that'll be incorporated. So again, key things to keep in mind, APCD, it does collect detailed data. It's from a subset of payers. ERISA's a big gap there, and it does not include non-claims based. The HCA data call has aggregated data that includes some ERISA plan data. It does include non-claims based expenditure, and it's at least somewhat easier to update potentially. So when trying to identify where specific gaps exist in collection of data, we started by trying to inventory what are the lessons learned, where were the pain points for others that have gone through this exercise, including some of the things that were identified through prior Washington efforts to calculate primary care expenditure. So specifically OFM's prior work in this area. They did a really excellent job, and part of that was documenting thoroughly where they had identified gaps in data availability. What I would note is that not all of these things that we've identified are going to apply specifically to Washington, because you do have that second data collection mechanism. So just to give you a little bit of flavor for some of the types of challenges, incomplete payer participation in data reporting is obviously a gap. The location type in APCD data was previously unavailable. There's a risk of inconsistent application of reporting methodology when plans self-report. That's not an APCD issue, and that's something we're going to talk about a little bit more. There can be difficulty in isolating the and isolating the primary care component of expenditure when it's included in bundled payments. Difficulty isolating primary care component of expenditure when it's in an FQHC or an RHC encounter, depending on your definition of primary care. Difficulty isolating primary care payment when it's part of a comprehensive payment, such as part of a capitation that's made to an integrated system. Medicare fee-for-service data is lagged fairly significantly. That's really focused on the claims-based side. On the non-claims-based side, and these are largely lessons learned taken from our two presenters last time, but isolating primary care expenditures and non-claims-based payment services that are part of a broader scope of services. So that's similar to on the claims-based side, but this is for non-claims-based payment. Also, one of the, I think the key things that was highlighted in the presentations is that it's important to have a standard categorical framework for non-claims-based payment by subcategory. And there was some feedback from the committee on that, or actually some clarifying questions in the last meeting. So hopefully that helps jog your memory a little bit about what we were talking about there. And then lastly, there's a risk of inconsistent application of a reporting methodology when plans self-report data. So similar to the claims-based reporting. So just to take a step back, some of these things apply to the APCD as a data source. Some of these things apply to the HCA data call. And some of these things just simply don't apply in Washington based off of what infrastructure you already have in place. So we did a very high level gap analysis that really tries to parse out where we need to be thinking about strategy and policy. Essentially, we found that there's two categories of areas to lean in on. So you have the actual data collection mechanism. How is the data collected and what are the implications for consistency, completeness, and ultimately accountability? And then the standardized reporting framework is the second major category. So what data is reported and how is it organized?
Hey, Shane.
Yes.
Sorry, really quick. I think David has a quick question.
Oh, perfect. Thanks, David.
Yeah, hi Shane. I don't know where this fits, but I think we could potentially add a bullet somewhere just about the fact that the definition varies in terms of the 4% current state was calculated based on one definition. I think that might have been the OFM definition. The 12% target was calculated on the Colorado definition or some other out-of-state definition. And we're going to be measuring based on the definition that we came up with, at least on the claim side. So we may have some policy considerations to take into account based on the different definitions. I suspect the impact will be slight across those definitions, but that's something that we can hopefully pay attention to as we're pulling the data for submission.
Yeah, and I think we can veer just a little bit to talk about that. I think that's such an excellent point. Part of when we're thinking about, well, you have two separate data reporting, I'm trying to find it, two separate data collection mechanisms, and there's pros and cons to both. The aggregated data call really was built to support this process. So clearly it's solved for a lot of the challenges already. But to the extent that, you want to make changes in how you collect data in the future, if you wanted to, this is part of what we'll be talking about. This whole point about the integrity of that statistic and interpreting it when you're kind of messing around with definitions and even how you collect the data, I think that's a great policy. Part of what we'll be doing is collecting a set of principles that we want HCA to apply as it's collecting data. And one of those, I think, would be to maintain consistency and integrity of the statistic, which means applying processes consistently over time to the extent possible. So I think it's a really good call out. Yeah.
Thanks, sounds good.
Sorry to derail you there, Shane. Just wanted to
No,
make sure.
thank you. Sorry, I get so excited about the data.
No, it's okay. You're all good. Yeah.
All right. Yep. So we have these two big picture categories again, just to hammer home. So the data collection mechanism, how you're collecting the data, of which status quo has two, and then the standardized reporting framework, which is what is reported and how is it organized. So we're going to talk first about the data collection mechanism. The great thing about you've already made progress here, which is excellent, because the fact that you can develop a Washington-specific primary care definition and then turn around and implement it as part of your next data call, I think is fantastic. That just means that you're pretty far ahead of the game here. So status quo is you're teed up to do this work. So you can modify the definition, incorporate the primary care definition, and you're already solving for some of the missing data elements that were challenging in the APCD. So specifically, you're collecting things like expenditures for non-claims-based expenditures. Additionally, to the extent that some of the data elements that might be included in the primary care definition that aren't in the APCD, those can be included in the specification and pulled down as well. So all of that said, you have this excellent foundation, but there are some challenges with it. And I think where we really want to engage you all is thinking through, are these challenges, things that you can live with, or things that you want to see changed, or that you feel like there's an opportunity to improve on in the future. Some of these challenges include that, and I believe Oregon made a comment about this particular challenge in their presentation last time as well, that when multiple entities are calculating primary care expenditures based on state-provided specification, there is the opportunity for inconsistent application of the specifications. Additionally, self-reported aggregate data reduces accountability and transparency. So for example, to the extent that there is a mechanism that holds payers accountable for marching towards the 12% primary care expenditure target, to the extent that there's wiggle room and interpretation in the specification, that there isn't a way to validate it, that there isn't a true accountability and transparency mechanism in the same way as having the detailed data. And that may be fine. Honestly, it's really just this is a potential weakness and not necessarily something that needs to be solved for. But we want to be really transparent about what does happen in the current process and what some of the potential weaknesses. Lastly, the process is administratively burdensome and partially duplicative with APCD reporting by plans. So just taking a step back and thinking about what you're trying to accomplish, what your current process is for accomplishing that, and what some of the potential weaknesses are, these are them. But again, I do want to point out that these may all be fine, that you may have already solved for the best solution that you can get to, because no solution is going to be perfect. So here on the next slide, we do want to point out that some states have updated their own data collection through their APCD to solve for some of these same challenges. So to collect non-claims-based expenditure and other data elements relevant to primary care expenditure calculation. That said, a few grains of caution. It might be an intuitive reaction to say, well, maybe we should just update the APCD so we can solve for those problems and have a single process. However, some payers that optionally report aggregate data may not opt to report the detailed data. So we are talking about ERISA plans, and how one of the nice things about your aggregate data call is that that aggregation actually allows you to capture data that you wouldn't otherwise be able to capture under federal regulations. So going to a single plan, you may lose that benefit. Additionally, you're talking about something that's difficult unambiguously. So it would take significant time and resources for the APCD to become a single solution for payer expenditure reporting. This gets to the earlier comments. So changing methodologies from data call to APCD, if it became available in the future as a solution, would result in changes in benchmarks and expenditure reporting that could be disruptive. So really the conclusion here, you have two data reporting mechanisms. One, you've built really to address this specific need. However, It does have some weaknesses. There are potentially some solutions around that. One of them might be to look at the APCD, but that in itself, again, is no solution is perfect, would come with its own pain points. And I think some of them are non-trivial, such as losing some of the data that you're able to capture through your current process. That said, despite these challenges, it's potentially worth exploring. I think that one thing that might influence the broader discussion at the state level is what the broader long-term vision for the APCD is. To the extent that you do have other use cases that could benefit from bolstering the capability of the APCD, then it might make sense then to have this use case in mind as that infrastructure is built, and consider a longer-term strategy to limit the ways that you're collecting data and kind of streamline those processes. Okay, so, all right, so we have a poll here, and let me just tee it up here. So what we're going to do is really ask you for some principles that you would want the state to adhere to as it continues to refine its process for data collection. Just to recap, so there's really a primary methodology that you're using, this aggregated data call. Under that data call, the plans are calculating the aggregate data statistics, and then HCA is aggregating it, or further aggregating it. That process will 100% allow you to incorporate your primary care definition. We are doing some additional data analysis on Medicaid data to validate that we have all of the right data fields to align with your definition, and you'll be able to see some of that analysis and refine the definition if you think it's appropriate to do so. So what we're going to do is ask you to provide principles for the state as they continue to refine that and incorporate your definition moving forward. And David, I see you have a question.
Yeah, Shane, sorry to slow you down. I think I understand the trade-off that you've teed up. For me, one of the things I'm thinking about is it depends upon what level of analytic capability the recipient of all this information has. And I thought I remember Judy describing previously that there aren't any analytic resources allocated on the state side. Am I remembering that correctly?
There are some allocated to the cost board. And so to the extent that this is part of the cost board, we do have some. That being said, it's not enough for us to go hog wild on. And we are in the next steps part of this presentation later on, we are going to do a preliminary analysis to give you guys some more information about what the codes look like before we finalize them. So so there is a little bit, but there's not a ton.
Okay, because Shane, the trade-off really is APCD provides access to detailed claims data so somebody can go in and analyze claim level data, as opposed to data suppliers running the coding, the primary care algorithm on our side and just submitting a total dollar amount. Is that right?
That's one of, I think that's one of the primary trade-offs that you've characterized it accurately too. But I would say it's not the only one. I do think that the fact that the aggregate data call captures more plans data because it's capturing some of that ERISA data is non-trivial. You can't really get at that through the APCD that I'm aware of because of federal prohibitions on requiring those plans to report granular data. But it's also worth, I think, being really explicit about within that trade-off, why that trade-off matters. So there is the risk, and this really is just to reiterate for the group. So if you have 20 entities that are calculating something and applying a standard, there's a risk of maybe not applying that standard consistently and,
Yeah.
and that would be remediated. There's also the other trade-off of multiple reporting processes. So report to the APCD, also report under the aggregate data. It's difficult to say the magnitude of those problems, though. I don't think we have really good line of sight on like how painful some of those are or how much risk there is. Maybe the risk of variation isn't that high. We just don't really know.
Okay, yeah, that all makes sense. Did you consider as one of the options for the claims-based expense to run through APCD and the non-claims to be run through the data pool?
We haven't talked about that as an option. You would still have the data loss from losing the ERISA plan contribution. And I don't know if there's anyone else on the line here from HCA that participates in that process that might have a better insight to what the consequences of that particular strategy would be. And it's fine if not.
Yeah, I think it would be hard because you wouldn't necessarily have both claims and non-claims based from the same folks. So it would leave you being incomplete and sort of not knowing how far to be incomplete. Although as you saw with all of this that Shane laid out, there isn't a perfect solution. So that's why we want to chat about it.
Yeah, well, and I'm sorry to keep asking questions to you, but if completeness, that seems to be like a primary issue. Wouldn't that just rule out APCD from the get-go?
Actually, yeah. And I think the question of completeness, it's kind of, I mean, from a mathematical perspective, completeness is only a problem if the people that don't report have wildly different utilization patterns. So it's just kind of hard to say because you just don't know what you don't know. And in fact, we don't know how much expenditure is in the unreported category, even through the aggregate data call, because you just really can't ask for that data.
Yeah, okay, thanks.
And yeah, I mean, it's a question. Do we want to emphasize completeness over other things, or do we want to emphasize ease of data collection, or sort of something else? This is what this poll is all about, because we need advice about which is the best way to go from all of you.
And thinking longer term as well, I think the principle that you brought up earlier about different definitions, I would reiterate that does sound like a good principle to include, which is to try and maximize the stability of the definition over time. And that in itself would actually have an implication for thinking like really, really big picture about trying to get to a single data solution off in the future. Because that for sure would reduce some instability in the statistics you're reporting on. Any other comments or questions? I know the idea of principles here is a little bit tricky, but I think that just hearkening back to the conversation, I think you saw how the level of detail can get pretty intense, and you're uniquely situated in that you do have what is honestly quite a good solution in place already, while acknowledging that it does have some weaknesses in it. So let's see, Michelle.
Sorry, trying to get all my permissions here. I just wanted to clarify as well the difference between the two data sources. Under the detailed data, would that imply that HCA would be doing the aggregate to come up with the primary care definition, applying the codes and the logic that we determine here, versus in the aggregate data call that would be upon the payers have to do that, or who's ever submitting would have to apply that methodology, right? Is that kind of one of the primary differences really between the actual data coming in?
Yeah, that's one of them. That's one of the biggest ones, actually. I think in terms of where there's potentially challenges, but you know, it's so hard to say. Like, we don't know. Maybe every payer is just you know, coincidentally interpreting the specifications exactly the same and that their data is similarly structured enough to do so. We don't know if that's a real problem. We're just trying to highlight, you know, to the extent things could go wrong, here's an area. But yeah, that's definitely one of the top 3 areas. So
Okay.
number of sources, who does the calculation, and then the other big one is, you know, the formatting and actual underlying availability of the data, like who's reporting.
Okay. I'm just noodling.
No, that's good. These are good questions.
Yes, please do keep the questions coming because, yeah, we thought this would be sort of the best way to kind of set up. And it really is, there's no perfect answer here. So we should all try and understand the pros and cons and make sort of the best part of a decision.
Andy, it looks like you had a question.
No, more of a comment. I mean, just, you know, having worked with a lot of this data before and the way it comes in, you know, it is easier if there is one person applying methodologies across all the data versus having each person for each entity calculate on their own and then essentially hand you the results. You know, when you're trying to get data from a multitude of entities, it's one of those where having the parameters around what data gets submitted is easiest, and making their job as easy as possible and having the data come in the rawest form possible too. Counts, individual numbers, those are the best things to do, and then let a different entity apply the methodology across all of the different groups. I think that's just, you know, that's what we've just found over time, especially when we're doing APCD. You know, all the data comes into the APCD, and then OnPoint applies methodologies going across all of the different data streams so that the final data file, analytical data file that is developed is consistent. So the same methodology has been applied consistently across all payers.
That makes sense. One thing I want to point out with this poll too is I think we've had others similar to this where you can up rank and down rank stuff. So please do that as well if a particular principle resonates. For this piece, so just to think about process, so that there obviously is devil in the detail, which you saw in spades in the last meeting. So we'll take these principles and meet with the staff that are supporting this work, and you know, to the extent that there are opportunities to like lean in on certain areas that then like based off of the principles that you're providing today, and then we can see what those policy options are and bring them back. I know the question came up earlier about resources. This might feel a little bit weird, but you don't necessarily have to constrain yourself to what resources are available today. Part of your policy recommendation back to the legislature could be to provide resources to do something. That, you know, of course, is you have to weigh, you know, political feasibility with how important something is to you. But I just want you to know that, you know, that's not off the table if you feel strongly about it. Yeah, auditability, I think while it's up there, that's maybe something that when we're thinking about that concept of hybrid options, this would be something that is, you know, drawing additional resources, but maybe there's the ability to audit portions of the claims-based data with APCD. We'd have to talk about that with the team that collects it, because the aggregate data call includes utilization that's not reported in the APCD. I don't know. There might be a way to split up the data to where you could audit a portion of it, but I think we'd need to dive in on the details with the people that do that work.
Yeah, Shane, this is Sharon. And what I meant by auditability isn't necessarily something super in-depth, but I just know, for example, from the work that we do at the Washington Health Alliance, we will look to see every time there's data that comes in, if we say, oh, this is coming from KP, we would expect to see this many claims. And if we expect 3,000 and we get 90, then we have a problem, right? So that sort of thing.
So like reasonability checks
Yeah,
on the data.
reasonability checks. Yeah.
Not necessarily an in-depth audit. That makes
No.
sense. Yeah.
Yeah. Okay, thanks for clarifying, Sharon. And Nancy?
So I apologize ahead of time if this is really stupid or too far out there, but what you said about, not being limited to what we already have. But are there any models where there's some auditing or some counting of provider-based rather than payer-based systems? Again, I'm sorry if that's too far away from where we are.
My turn to apologize. I'm not 100% what you mean by a provider-based. Could you just elaborate a little bit?
Yeah, I mean, everything that I'm looking at is the payer-based reporting, right? But the provider submits the claim to the payer and the payer pays it. So instead of getting the data from the payer, what about the provider who actually provided the service? And again, I'm sorry if that's too far away from where we are, but I'm just wondering if anyone ever collects directly from the provider rather than the payer, the service provider.
Not that I'm aware of for claims-based expenditures. And part of that is because it would probably be pretty burdensome on providers, and payers already have that data by virtue of having to adjudicate the claims and pay on them. I think the reality is that would be quite a significant lift, and I don't think providers would like it a ton, to be honest. But I mean, it's maybe worth exploring. I'm just not familiar with any solution around that. I haven't seen that done mostly.
I think the hard part of that would be providers submit a bill, but the payers only pay often a portion of it because they have different little ways of making agreements and stuff like that. And so I think it'd be really hard to tell, like, oh, you're with Regents, so you get a 10% off of charges. And I'm totally making this up because, yes, we won't go there, but or you're with Kaiser, so you get a 5% bit off of charges, but it's often different for different things. And even plans within regions can have different
I mean, I guess this
amounts.
is exactly my point, is that what's actually the service that's actually being provided to the patient is diluted or is altered through the lens of the payer in a way that's not necessarily optimal, right? And so if you really want to count what actually gets done, you're going to get a much more real, I don't want to take this too far off topic, but you're going to get a much more genuine view of what is actually happening from the provider rather than the payer, because as you say, the payer decides to pay this or that or the other thing based on some, random code. And right now, at the moment, they're paying noticeably less than they did a little while ago because we keep getting these denials.
I wonder if that, I wonder if we can flag that, we'll flag that as part of the discussion with the internal group to see what options are out there. But I think that is pretty well aligned with, I saw it a minute ago, but the completeness principle here. What you're suggesting is that when we're looking at utilization data, it isn't complete because it's been run through a filter of, the whole payment dynamic that's not capturing the services actually rendered. That could be actually relevant for, thinking about policy in the future. So we can certainly flag that as like we need to explore that through that specific lens in addition to the broader concept of completeness.
Thanks.
Other comments or questions?
Hey, this
All
is Katina. Just thinking about the last little discussions, I appreciate the horrible burden that would put on providers, but I think that's a really interesting concept to consider. Like, what are we leaving on the table? We're not getting paid for the work that we're doing, and how do we account for that? Or when we are getting paid, we're getting underpaid.
I think we can tackle that too as part of our next discussion when we dive in on policy. You know, the 12% is a little bit North Star, so it's giving you direction and kind of relative magnitude. I think when we get into, we've actually started to map this out, is like, how do you get rather specific about the policy recommendation? So for example, when we talk about, well, what does, one of our policies is pay primary care more, so direct investment. Well, what does that look like? And I think maybe when we get into the details of that, and particularly when you start thinking about, well, it's not just enough to pay more, it's also how you pay, and thinking about alternative payment methodologies where, you know, kind of getting off that whole fee for service cycle of every little thing. It starts to matter less whether or not it's a compensable service, because you have greater flexibility to deliver what's needed as opposed to what's revenue generating. So let's maybe put a pin in that concept and then hit it really hard when we get to talking about payment policy and policies around reimbursement in our next meeting, because I agree that's actually quite an interesting idea. If part of the problem is we're not providing the monetary value for the service value, there's a gap there. We should look at that. All right, I know that this is pretty high level, but again, I think this actually is still very useful because it's showing where there's some prioritization, and we can bump this up against current processes, particularly after we've integrated the definition of primary care that you've come up with, and we can see, well, this is valued. Where could we modify this process to maximize this principle? And to the extent that we can shake out any potential modifications to current process, hopefully we can start to highlight those for you as we start to transition eventually into the operational planning. So. All right, so just a quick summary at the top: consistency, completeness, ease of submission is the top three, and then we had a good list going down. Oh, consistency is really important. We got it twice. Quality assurance, auditability, ease to collect, ability to create the analytical files. Does your process do the thing you really, really need it to do? Pragmatism. HCA having the ability to.
I think those last three are pretty interconnected with
how the data is collected, and then the second bucket was around the structure. We started off by reviewing the specific data delineation, so the categories that needed to be reported. So it's like by payer, delineating between meaningful categories of service, that type of thing. So those obviously will be baked into the process. The other thing that came up and is part of what we talked about in prior meetings is reporting by some sort of stratification, like what type of payments. And actually this goes back to what we were just discussing, is how you pay matters, not just what you're paying for. So are you paying under a capitated agreement that has a lot of flexibility for the provider to just provide the services that are most clinically relevant, or is it fee for service? So ultimately, you know, the state's going to have to develop an allocation methodology also to estimate the portion of payments that are not explicitly for primary care, but include primary care. So three things here. There's baked in stratification and statute. There's reporting by type of payment, and then there's some sort of allocation methodology. Kind of the same idea here, where there is a level of detail that would be a little bit crazy making. So we're going to try and keep it slightly high level. But we're going to talk first about the reporting on type of payment, and then we'll talk about, again, some general principles as well. So if you remember from some of the prior meetings, this idea of reporting by the Healthcare Payment Learning Action Network framework, that framework essentially has four major categories. The four major categories essentially start with fee for service, and then they progress up into more comprehensive payments such as population-based payments and capitation. This framework really is used nationally. It's caught on since it was introduced. They're actually making some updates to it, or have done so recently, to kind of recognize the reality of implementation on the ground, I think is the primary goal. But the question in front of us is, do you support using that national framework as the categorization strategy for reporting on type of payment? We'll give people a minute here to respond. What was our count? I want to make sure we're over the approval threshold here.
Yeah, 13 is generally what we counted earlier. Maybe folks are just pulling it up.
I'm on mute. Yes, get on and vote. I think we have 13 people still.
Yeah, I thought we did too.
This is Katina. I vote yes, but I can't click on the vote.
Oh, okay, gotcha. Thank you.
That's helpful. So it's really 11.
I think we might have lost some people talking about data infrastructure.
Hello, this is Sharon, and I didn't vote because I don't know what the HCP land categories are.
Okay.
I mean, there's a lot that they have a jillion webinars and stuff, so I don't know what it is. So I have to abstain.
Okay.
Tell you that part of it is Learning Action Network. But yeah, it's value-based payment categories.
Yeah.
Yeah.
It's really just adopting four categories that stratify the amount of risk that providers are taking for payment. Another way to frame that is how much flexibility they have in getting payment. So is it a guaranteed payment and you render whatever services, or is it just per unit of service? So category 1 within the framework is fee for service. Category 2 is like fee for service with starting to get some incentive payments or some infrastructure payments. Category 3 is where you start to see bundled payments or episodic payments, or for limited conditions. And then category 4 is where you get into population-based payments. The reason why you want to incorporate this type of stratification in your data reporting is because it really does matter. I know we've had a lot of conversations about value-based purchasing and alternative payment methodologies, but if everyone's still paying fee for service, even though reimbursements increased, you haven't necessarily done justice to improving the sustainability of payment in the system. So it really is I think when we get to talking about policies, I'm optimistic there'll be some recommendations around APM adoption and all of that, because it really is part of sustainability. So we want to make sure that it's in the reporting requirements, because ultimately that's going to support you with driving policy as well.
And I'll say that currently HCA does use these categories. We currently collect in a way that that can be improved, but we collect non-claims based data from the payers that we contract with, and we use the LAN categories for that.
All right. Well, I think we
Don't
do
need
need to.
all 13, Shane, for the record. We have 13 people here, but we need at least half.
Oh, I'm sorry. I thought you were saying that was the threshold. Okay, we're
Yeah.
great. So people generally support that, which is great. There is definitely an advantage to aligning with the framework that's used nationally, of course. It's great. All right, I will lock that down. The next question here. So let me just go back up here. So thinking about specifically standardized reporting formats, we do want to just, we won't spend as much time on this one as we did the last one, but you know, to the extent there are principles of, you know, as you're thinking through some of the implications of standardizing reporting and using these frameworks, any principles that stand out, feel free to note them here, and we'll up and down vote, and all of the same comments apply. We'll go back, work with the people that run this process, see if there's an opportunity to maximize some opportunities to that like really build on the principles. So we'll give you a minute here, and feel free to populate, and then we'll switch over and we'll start to talk about codes, and then we'll switch over to policy.
Just a quick procedural reminder for those who are attendees, if you have questions, those were for a public comment period. So this questions, comments right now are reserved for committee members. So I think I saw a hand pop up earlier, but I just wanted to put that out there. You can always submit your questions in writing if you have them. Please feel free.
I apologize, Shane. Can you clarify what you mean by reporting framework?
Yeah, so currently for the aggregate data call, there's a specification. It's like, please report this way. And within that framework, there's an opportunity to modify it. In fact, I think there's a couple of areas where we'll need to do that based off of whatever principles identified here. So alignment with the HCP land, making sure that that's tight, maybe looking at some of the stratifications per the presentation from Michael Baylett for non-claims based reporting. If there are, so this is really about the, so before we were talking about who you're how you're collecting data, which included like the actual mechanism and the who's doing it. And then this is really focused on the what you're collecting and how it's organized.
Got it. Thank you.
I know those concepts are pretty close together, so that's very good.
David, do you have a question?
Yeah, Shane, sort of follow-up question to Jonathan's. Is this reporting from the carriers to the HCA, or is this HCA reporting to the legislature?
This is specifically on defining how the payers report to HCA.
Okay, I'm thinking about Mandy's earlier comment. You know, when we were filling out this submission last year, the criteria were fairly explicit, and even then we felt like we had to make some interpretations, and that other carriers might make different interpretations. So is something like detailed criteria the kind of thing that you'd envision here as a principle, or is that just a given?
You could include it. In fact, as a principle, you could say have a stakeholder has a stakeholder process to ensure that maybe includes payers, that you're identifying where there's potential ambiguity and providing clarity. So I think you could go even a step further if you wanted.
Okay, thanks.
Yeah. Mm-hmm. All right, so still, okay, great. Ability to track data over time, transparency, align with industry standards when possible, include demographic information to track primary care investment with an equity lens. That's a great call out. I honestly don't know what the demographic stratifications in the current data call are, but we can look at that and see if that's an opportunity to improve to the extent that that principle resonates with the rest of the group. Ability to break down below state level. That one is in fact a requirement of statute. So it's broken down by payer. I think there were other stratifications as well. So for sure that'll be included. Ease of access. All right, we'll give you 30 more seconds here and then we'll keep going. All right, transparency at the top, demographics bumped up a bit, ability to track data over time is the top three. So, right, thanks for going through that exercise. I do want to, before we go on to the next topic, I do want to pause briefly. The strategy that we use to approach this conversation, which spans back more than one meeting, was to help you understand essentially the complexity of the lift and some of the challenges that you have to address. And then today, we helped show you how this process unfolds currently and what some of the pros and cons of that are, and talked about potential alternatives at a high level and the pros and cons of those alternatives. But ultimately, the strategy that we adopted is to collect principles, and then we'll be charging the staff that do this work with evaluating these principles and seeing where there's opportunity within processes to align as much as possible. And then that will hopefully result in some things coming back through the operational plan. I do want to just for a moment or a couple minutes here, we have presented a lot of information over the last few meetings. Was there any topic related to the data collection and data reporting that you felt like you wanted to share your opinion on or ask questions about, that this particular strategy didn't leave you the opportunity to do so? We can take a moment to make sure we capture that and potentially address that in future meetings. Okay, so it seems like this worked for you. Okay, that's good to hear.
If you're feeling reticent right now, I'll just put it out there too. I think you can always email the inbox and shoot us questions. We try to get back to you promptly, and we do take that feedback into account. So I know some of you prefer written communications rather than being put on the spot in a group, and I understand that. So.
All right, well, let's move on. Code review finalization. So there's going to be two pieces here. Both should be pretty quick. So we are trying to tie things back to the charge every time that we go through a topic, but you can see that this is obviously related to the primary care definition. We did receive an email. One of the astute committee members identified that the code for IUD removal was not in the list that you all voted on. However, the committee did approve including IUD placement codes, so that felt incongruent. So we wanted to ask the group, would you approve adding code 58301, which is removal of IUD, adding that to the primary care definition code set? We actually didn't set up a poll for this. How do you typically vote absent a poll, Dr. Zerzenthal?
We could probably just do a voice vote, I think.
Okay.
So do people have any questions about this? I'm trying to find my script of the motion that I'm usually do. I think, is there a motion to approve adding removal of IUD to the primary care set?
So
I'll make
moved.
the motion. Yes, or I'll second, yeah.
Excellent. Any discussion? Okay, so I'll just do a verbal, all who approve say aye.
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 And I'm an aye too, and all who disapprove say nay. Excellent, it's unanimous.
All right, we will add that code to the list. And thanks for for whoever caught that. Thank you very much, and then thank you for voting on that. So speaking of finalizing the code set, or finalizing, HCA staff were kind enough to work on a utilization analysis. I believe they're still in that process, actually. And they're essentially pulling down utilization and expenditure data stratified by location and all of the different specialty types. This is specific to Medicaid utilization, I believe. And what we're going to do is start to try and answer some of the questions that you all had where you thought that, some data would be helpful for answering this question. So we're going to focus on 2 cases, and then we're also planning to do some provider location analysis to see how your primary care design aligns with where we're seeing code utilization and for the providers that were included in the primary care definitions. So the 2 cases we're really going to be focused on to bring back to you, so that we're not bringing back just massive amounts of analysis to try and sort through. We'll focus on where the committee voted to include a code, but for whatever reason, it happens to be quite low utilization. That could be the case. It could be the case where there's low utilization for primary care, but it's high utilization for specialty care, and that might warrant taking just another look at that code. The other case is the opposite. So it's where the committee voted to exclude something. Yet we're seeing that when you apply the service location and the specialty types, there's actually high utilization for that code. And so we might, we'll flag those to the extent they exist and have some discussion about those and sort out that code list from a data informed perspective. Again, we do plan to look at the provider location to see, I think there's actually an interesting question here of, does it matter? If you're narrowing down to codes and specialty type, will provider location be a meaningful delineator? And we'll be able to test that a little bit. Also, it'll provide information on different types of locations that might drive some interesting questions. So we'll see how that analysis comes out, but we're planning to do that. We did want to ask you, though, are there other specific cases that you can think of that you do want us to explore and bring back to the committee through that analysis process? Or are we being a little too narrow here? David?
Yeah, Shane, you might guess based on my first comment, if you have the ability to analyze where this definition differs from the definition used for the 4% baseline and the definition used for the 12% target, that would be interesting to me.
Okay, yeah. I think we have the we have this really impressive workbook that shows how every state incorporated codes, but it does include the broad and the narrow definitions that were previously used for Washington as well. So we should be able to pull that out. I haven't seen the analysis yet, but I believe we'll be able to even wrap some numbers around where those differences are, which I get where you're going with that, because it could have implications for if our baseline assumptions were wrong, then it could have implications for where we're going with future policies.
Yeah, okay, thanks.
Yeah, absolutely. Anyone else? Is there any specific case? Oh, Nancy?
I guess I had you mentioned that you weren't enthusiastic or perhaps optimistic that the location. I mean, I've mentioned this all along. I think location is critical, but the question is it like physical location or, you know, because our definition incorporates a team, right? And so when I think of a location, I sort of think of as a medical home or a team that takes care of a patient rather than, you know, this particular provider is at 3rd Avenue or Hobson Clinic, right? So I'm curious, I'm very curious about how that location will be defined as like a physical place or a location within a team, I guess.
It's
So,
definitely
Corey,
a physical place because
Yeah.
there isn't a way to get down more into it. And so, yeah, it's the address of where the provider is.
Yeah, specifically where the service is rendered.
But I think if the service, it's still like if you're telehealth, it's still at the clinic, not at the wherever the person is.
You had a question?
Sharon?
Me? Hi, yeah, I'm just thinking about the locations of the services that are given. I think it makes a lot of difference because many of the codes that we have approved says things like, you know, if an ARNP is visiting somebody at a nursing home, then we have to know that that claim has the right place of service code on it. And I was just reading something yesterday about price transparency. And one of the major problems with price transparency is that the biller for some services with the increasing consolidation of healthcare, you know, around the country, I think it was a national thing, but in our state, we certainly have a lot of consolidation, is that let's say that, you know, somebody goes to an outpatient service that is, or a clinic that's affiliated with a big hospital, but the system billing office may send out the bill from the address of wherever that's coming from, which may be inside the larger hospital or some office building. Instead of putting in the place of service code like they're supposed to do. I mean, I don't know how easy it is to mess that up, but apparently it is messing up our ability to understand price transparency. So just serving up another problem there.
Yeah. Did that article have solutions?
No, it was just really decrying the fact that there are so many ways for organizations to kind of game it, and maybe not intentionally, but to make it really hard for us to understand where the money is being spent. And this is particularly, I think, in light of kind of large systems that incorporate both hospitals and outpatient places and, you know, outpatient individual providers' offices versus what we used to call hospital outpatient departments, where those HOPDs can really rack up the charges for some reason. And yeah.
I mean, I would honestly flag that as a data collection barrier, given that the definition does rely on service location. So that's something we can certainly flag. I mean, I off the top of my mind, don't know what types of strategies could be implemented to address that specifically, but I think that, you know, to the extent that this work group has ideas, it'd be worthy of flagging.
I will. I just because I'm curious, and I know it's not the Washington APCD, but I'm going to ask our data analytics manager to check through the Alliance's APCD to see how do we feel like we have, for instance, the number of claims that would be coded to have taken place in an emergency department, because there's a place of service code for that. Just one of those reasonableness checks to kind of see what's out there. But if, and what percent come in with no or kind of a nonsense place of service code. I think that's something that we should probably both do to check back through.
Yeah, well, if you're willing, we'll take you up on that.
Yeah. Thanks so much.
I'll ask him to take a look within our database, but yeah, of course it's a little bit different, but I will.
Yeah, the source data you would expect to be still the same. So hopefully it would be a meaningful, anecdote.
Cool, I'll do it.
Thanks, Sharon. Jonathan?
Yes, just a clarifying question. For the methods for combining who, what, where for location, is that using the methodology presented by the Vessel Lab in a previous committee meeting, or is that with a different methodology? From the methodology from the University of Washington researchers.
Yeah, sorry, Shane, I'm jumping in, but it was partly inspired by that for sure. That's where we got the emphasis on location, was from the University of Washington. So they were one of the key players who influenced our decision to incorporate it, put that in front of you all as a choice. So does that get to what I think that gets to what you're asking.
Yeah, just wanted to make sure I had a good understanding of what the next step was, and I felt like I had a grasp on what that process was, and so that's helpful. Thank you.
Cool.
When we bring the analysis back, we'll do a brief summary on what the methodology to pull that data was, just so you have the context to make sure that we're applying conclusions right as well. So,
yep.
Thank you so much.
Any other questions or comments? Kind of back to that original question, we're trying to hone in on a couple of really specific cases in the data analysis to keep from overwhelming you. Are there any that fall outside of the ones we've identified here that you think would be important for us to actually bring back? Okay, well, I think just based off of the prior conversations we had while going through the list, this is actually going to get you through a lot of the concerns that were raised, and I think it will be interesting. Maybe my interest was premature in the location. It sounds like you all feel pretty firmly that that's going to be really impactful, and then we would expect to see that in the data. So I'm excited to see that. It really is interesting. I'm really happy that HCA was able to do that, and I'm glad that it can inform this definition so that we can hopefully keep it stable over time versus after our first run finding that we need to make some tweaks to it when it's live. So, all right, thanks very much for that feedback. The next section here that'll wrap us up is around policies to achieve the primary care expenditure target. You can ignore the blue at the top, sorry about that, but it's really focused on these two charges. So recommend methods to incentivize achievement of the 12% target, and recommend specific practices and methods of reimbursement to achieve and sustain primary care target. We kind of took it one step further in that we created a 4-domain framework here. And this is all kind of acknowledging that supporting primary care is more than just direct investment, that there are other things that have to happen in concert with that for it to ultimately be effective. So again, the quadrants were direct investment, capacity growth, which would include things like reducing barriers to spending time on patient care, and workforce investment. So, if you're going to increase reimbursement, it's nice to have people that you can pay. Patient behavior is another key category. If patients, which I've heard anecdotally is actually slowed down a bit, patients seeking primary care post-COVID. Patient behavior, if patients aren't going in to get primary care, it's going to be hard to advance that 12% target. The first step is obviously getting them through the door to get services. And then we have this fourth quadrant, which is reduced expenditure on other services. We've narrowed that to really be focused on when we're thinking about calculating that 12% target, just acknowledging that there's going to be benefits from having access to primary care that we'll have to account for, such as hopefully reduced emergency room utilization and exacerbation of conditions that would result in hospitalizations. So this does go a little bit more granular and past the charge, but I do think, particularly given the conversations we've had, that there was a recognition that you really do have to think a little bit broader if you want to truly support primary care. So just as a reminder, we took an initial read of the room and had you all react to some ideas that were things that were actually implemented in other states, but also gave you the opportunity to throw out your own ideas and have them up or down voted. This list here of 11 was any idea that had at least some favorable reaction to it. So direct investment being the top, just, you have to pay a bit more. Capacity growth, focusing on reducing administrative burden and cost for providers. I'm not going to read the whole list. I think this is what we came up with before, but we really are going to have to start to get more specific, like what does it mean to increase primary care reimbursement? Like that's a pretty vague statement in general, even though we all generally know what it means. Like who would be responsible for what actions for that to be a meaningful policy? Excuse me, talking for too long. So the next thing we looked at also was data related strategies, kind of on that provider support domain. And you could kind of bucket this under the capacity growth to the extent that these things maximize what resources you have, but investing in EHR as a service, electronic consent manager to reduce burden from collecting, like trying to get consent, so ease of access to information, that type of stuff. So what we're going to do in the next meeting is we're going to come back to these policies. I think it's going to be a really fun conversation because this really is, doing the hard thinking about what needs to change in the system from supporting primary care globally perspective. And we're going to do a couple of things. We're going to refine that list to make sure that we have a set that the majority of the groups is comfortable with bringing back to the board as recommendations. We're going to really focus on getting to a greater level of detail so that it's not just a general statement of like more of a principle, but what are the more specific action steps that would need to happen for that to work. And part of that will be things like identifying, well, who's even responsible for that? I think one of the examples was like removing the penalty from people violating their non-compete clauses in the case they stay in Washington to practice medicine. While that's probably not an HCA body of work, that might require legislation. There's specific stakeholders to be involved. And I think we need to just flesh those out a little bit more and validate that those are recommendations that this group would support. So once we get to greater level of detail, just maybe mapping out a really high level strategy by which those things might be implemented. And then as part of the charge, talk about the accountability and incentives for the different actors that are responsible for executing the policy to ensure that they actually do it. So, and that's going to look different for each policy and for each actor. One of the key ones that we do have to focus in on as part of the charge, though, is this concept of getting payers to work towards the 12%. What are the levers? How do you incentivize them to do that? So I just want to flag that that'll be a pretty big focus because we want to make sure that that's addressed as part of our charge, while at the same time acknowledging that we are taking a slightly broader approach to think about primary care supports more comprehensively so that we have what is something that'll be truly impactful when it's actually implemented. So it makes it all the way through the process. So we're not really diving into the policies today. We just wanted to keep these things at the top of mind before we get into the next conversation. So that actually leaves us with half an hour, but let me open it up and see if anyone has any comments. They could be related to the data conversation we're having earlier, anything about the code set, or anything about our future policy discussions. So what's on your mind?
Not so much, or overwhelmed, what's on their mind. Well, I'll just stop there.
I think it's more the latter for me, is that every single one of those I was looking at going like, oh boy, how do you do that? And one of my many questions is, let's fix how primary care providers are paid and let's pay them more. And I guess maybe through the Medicaid programs that could be addressed at the state level, but it seems like, the way things are coded and the way they are reimbursed for tend to discriminate against primary care providers because they don't do many, the type and level of procedures that are the most richly rewarded, things like big surgeries and stuff like that. And that would have to get changed at the federal level, wouldn't it? So I'm like,
Yeah,
how
I
much
think
of it?
that's a good point, Sharon, to think through like what's within the state scope versus what's outside of our scope. And that kind of gets to a question around list refinement that I wanted to make a point on for this group, which is we want to, everything looks great, right? And so there's maybe a temptation to be like, oh, well, of course, that just makes sense. But we do have to think about what are the costs implied in these various things. Like when we talk about how much are we going to spend on primary care, who and how, right? That's getting to what Shane was talking about earlier. So we do need to get the granularity. We'll get into what are the criteria, concrete criteria that we are using to select these policies, right? We can't just kind of arbitrarily be like, well, that sounds great, let's just do that. And I don't think that this group is gonna, it is. But I think it'll be kind of a joint venture between our internal staff, maybe discussing what some of those potential criteria for refinement could look like, and then you also supplying your ideas as a committee for what those criteria could be, and then coming up with a compilation. That's kind of my vision. So curious to hear how people respond to that. I think that's a potentially practical way to approach. Maddie, you had a question?
Yes, so one of my questions is, and it might be that we need a review, but haven't some other regions of the country or entities started doing this? Yes. And so I feel like I would need a review of what did they do versus just a blank sheet of paper to be helpful with that.
To give you some groundwork. Yeah, okay. That's good to know.
I think it was two, it might have been 3 meetings ago, but we did, as part of the framework, share what some of these states' strategies were, including the type of statute that they passed to support it. What we're going to try and do between now and the next meeting, though, is to kind of go back through that same exercise and see if we can find specific examples of state policy that align with the types of policies that you all had expressed interest in. And also we had talked about, which it sounds like it would be helpful, just flagging where states that have pursued hitting expenditure targets, which specific policies they felt they needed to implement, and highlight those for you to the extent that they didn't make the current list. So we'll be sure to do that.
Jonathan?
Hi, yeah. I really appreciated how much background information we get in each of these meetings before we sort of share our thoughts on ways forward. And I've seen the announcement that Washington will be participating in the CMS Making Care primary model. And I think that could be helpful grounding information for the committee before next meeting. And so to the extent that any public materials are available, I think it might be related to the direct investment policy conversation. And so if anything that's publicly available could be shared with committee so that we'll have that sort of shared grounding and understanding of ongoing developments, I think that might be helpful.
Yeah, it's a great call out, John. Thanks.
Okay, well, maybe I will wrap us up. I think there's a wrap up slide.
I think it literally just says wrap
It
up.
just says wrap up. Excellent. Well done. Thank you all for participating in today's meeting. And I think we had some really good discussion. So as Shane talked about, we're going to continue our discussion of policy proposals and criteria for policy selection. I think it's not going to be ready for next meeting, probably the one after, but we'll also bring back whenever it's ready the data piece of it. So that may shift our agenda a little bit depending on how soon we can get it done. So thank you all for attending today. The recording and summary of this meeting will be posted on our website soon. And we will see you again June 25th at 2 p.m. Thanks so much and have a great day.